Thank you and good morning. Welcome back to our second session. I apologize, I'm getting a little feedback. I don't know if someone at the ASU team can take a look at that. Today we're going to be kicking off kind of the heart of the discussion for this learning collaborative, which really focuses around financial skills that we think are necessary to supporting your organization under payment reform or the shift to value-based reimbursement. We're going to examine really kind of initially at a conceptual level what's being asked of us as safety net providers and begin to talk about how organizations such as yours are addressing these challenges nationally. Just a reminder, I'm Andrew Principe, part of the faculty here. With me on the call is Amanda Stangus and Samantha Jones. Please feel free to reach out to us if you have any questions between the sessions or any comments that you'd like us to know. Just a reminder, today we're a little bit off of our normal time schedule. We'll be going for about an hour and a half today, but we have blocked, I believe, 2 hours, but we'll only be going about an hour and a half today. After this session, we'll get back on our normal schedule, which is Mondays from 11 a.m. to 12:30 p.m. Central Time. And so our next session will cover the second half of the content for then we'll talk about budgeting for capital and infrastructure requirements. In the fifth session, we'll be reviewing a case study. And then lastly, you folks will be making presentations about specific situations regarding your organization and the financial challenges or opportunities it sees value-based reimbursement bringing. Today, I'd like to take a quick second and talk through and discuss the homework from our most recent session. Then we will take a look at the kind of framework that we're going to use really for the remainder of this learning collaborative to discuss value-based reimbursement and its financial impact on safety net providers. Of that skill set, we're going to dive into the first of the skills, which we refer to as defining value. If you're going to be paid on value, we think the first and really kind of foundational skill is understanding what value means, how it's measured, and how we create a platform for value. And then we have a little bit of homework for you this week as well, really to just continue the interaction and get to know you folks better, as well as to enrich the discussion and the content. Last week, we asked you folks to prioritize these 5 statements. And unfortunately, and we apologize, it was not set up in the SurveyMonkey. It should have been there. So for those of you that were able to get it to us anyway, we appreciate that. Going forward, we assure you that the homework questions will, in fact, be available to you in the SurveyMonkey. So you really only have to go one place at the conclusion of each session. These are the 5 statements that we made. First, that maybe there's a concern that we don't know how to forecast gains and losses under value-based reimbursement systems. The second being that we don't understand the priority for the types of investments we need to make. The third is that we're not ready to make those investments. The fourth is that value-based reimbursements ask our organization to bear too much financial risk. And the fifth is that doing a better job actually has the downward impact or negative impact of forcing us to face declining revenue. And not surprising in the responses that we got, things were a little bit all over the map. And that's somewhat to be expected. One of the things we'll discuss as we go through this is that different types of providers, even within the safety net, are impacted very differently as it relates to these 5 statements. Since we got the majority of the homework via email and it came in, unfortunately, after we shipped the PowerPoint, I don't have a slide to show you the breakout of the responses. But as I mentioned, I think they were evenly focused or evenly distributed across the issue of not being in a position to make certain investments and not understanding the impact of entering into new models. Those two seem to rise to the top for the majority of respondents. In fact, and I'll focus a little bit on making necessary investments, one person went as far as to say that without a large capital infusion, it seems unlikely that we could make this jump. How do we get there from here without some type of infusion? On the side of forecasting gains and losses under value-based reimbursement, there seemed to be a consensus that this was a skill that was kind of lacking and certainly would be required or critical to moving forward successfully, but that it was something that could theoretically be attained in short order, that it was maybe a gap that could be closed a little more easily than, shifting or reinvesting in new infrastructure, reinvesting in a new care delivery model. Since we weren't able to get a complete homework from everyone, I wanted to turn the conversation to you folks and ask if anyone felt that one of the other priorities or priority statements was more important to them, and provide a little background on why that might be. Well, since I can see all of you on the line, why don't I ask if could the folks from the North Carolina Office of Rural Health, can you speak a little bit about your members or your constituents and their concerns within these 5 areas? Where do you think they would have the greatest concern?
Chris is coming to the phone. Hang on just a moment.
Hello. Well, I think, I'm looking at the slide that you have here, and I don't hear so much about number 5. That's not necessarily, I think if people feel if it's appropriately risk adjusted, that then they can potentially address that. So that one's not the one that I hear the greatest concern of. I hear more that we don't have the kind of resources to invest in preparing for this. There are, particularly the safety net, you're working on a shoestring budget to begin with. You're not the guardian gods and have resources, available. So I think it's the resources to put in place the infrastructure needed to then leverage that. Another one you don't have listed here, but it's a knowledge gap, and maybe you addressed it a little further on, is just the ability to know how to contract for and get a fair shake on that value-based payment with entities that are much larger or sophisticated. We hear a fair amount of that as well. So
yeah, we hear that a lot. The concern of, is it a good deal? Should I ask for more? Am I not getting enough? Or am I taking on too much risk for not enough upside? Yep, absolutely. Great. Well, thank you. Can I ask the folks from Piedmont if they have a slightly different perspective on this?
You said Piedmont, right?
That's correct.
All right, just checking. So I would echo what the colleague just mentioned in terms of the one thing that is probably missing that we would have loved to rank is the knowledge gap. I think the 2 areas that we couldn't necessarily rank and we felt like they were tied, and I think you have them as 3 and 4. We ranked them both as being equally number 3 or 3.5, however you want to do the math on that one. But we couldn't necessarily kind of pick one or the other, but that those both were kind of equally important. And then the one thing that was really just a less of concern for us is just being able to keep our patients healthy and how that might impact our revenue. That was not a concern for us at all. But, in terms of what is ranked pretty high on our list would be understanding how to forecast gain and losses.
Great. I'm going to ask for one more, if you don't mind. New London Hospital, would you mind commenting on how you see this as a hospital? I'd like to see if there's any difference in kind of your experience.
I think we're concerned with the risk adjustment as well. With our contracts, we don't have as many risk-based contracts now. So one of the things that we have looked at data on is what would happen if we did push towards a value-based model, and how much would it cost us? And it's not insignificant. So I think number 5 for us, from what we've seen in some of our colleagues in the region, is they've advanced their value-based payment profile while still in a fee-for-service system, and essentially are starving themselves. So that's a concern for us.
Sure. Okay. And I wanted to kind of get that perspective because as I kind of opened with, I think this touches each of us a little differently, and we want to be sensitive to that as we go through these learnings, that unlike other issues affecting the safety net around value-based reimbursement, the financial ones really do have a different impact on you depending on what type of organization that you are. Let's move forward and actually begin today's discussion. I want to kind of lay out how we intend to approach the content over the course of the next couple of sessions with you folks. And we're going to do that through a framework that really addresses the 5 issues that you just discussed. And as you provide us with more input, as you take the time to complete the homework assignments, again, I apologize they weren't set up. We've got that kink worked out. We do intend to kind of vary our content and really make sure that we hit the issues that are of the greatest concern to you folks. With that said, we're going to look at 4 sets of skills that we think are critically important from a financial standpoint in making value-based reimbursement work for your organization. And each of these is really something that we think not only is critical for your success, but where there's also enough of a best practice emerging that we can have some meaningful conversations around how to do this well. And yet there's no single answer to many of these issues. As we'll learn and as we'll discuss, many of the safety net provider peers of yours who have dipped their toes into these waters are really kind of pioneering how to approach these issues. We're going to talk about each of these 4 domains or skill sets, and really kind of drill down onto what's known about how things essentially are being evaluated. What are some of the key performance indicators that are predictive of our success in these models? Defining value, we're going to present today. We're going to present you with a kind of conceptual framework for defining our value in a value-based reimbursement environment. It's a framework that we've worked with other organizations as they begin their discussions and their negotiations around the type of contracts or payment methodology change they want to see. It really helps them think about the areas they can most directly impact. And it helps them really boil down what we think is pretty critically important to a small number of strategies that they can implement within their organizations to really start down that path of being high-value partners under these new models. It also helps really focus the type of investments that we need to make in order to maximize our value under that conceptual model. In a future section, we'll be talking about how value-based reimbursement models work, and specifically how to begin to think about your losses or gains under new value-based models. And part of that discussion will be a discussion around how far down the value-based reimbursement spectrum an organization can realistically go. And the answer to how far down that spectrum you go will have a lot to do with your ability to do some of the other things that we've already been discussing. Some might be in a good position to make certain investments and may have the risk tolerance or the financial cushion to test something riskier than an organization that's really just dipping its toe in the water and getting comfortable with some of the new skill sets that are necessary for value-based reimbursement. The third skill set area is around managing finances. And this is all about how we make sure that we stay on track. From the minute you enter a value-based reimbursement model, it will have almost immediate impacts on things like your cash flow, your margin, your cash days on hand, all of the things that we've done generally a very good job understanding and tracking to in a fee-for-service model. And now suddenly we kind of went and changed the rules. And so what are the types of controls that we need to have in place for oversight and to make sure that at the end of a performance period, we really end up being where we need to be from a financial standpoint. And given how much is unknown about how that might turn out, what are the protections that we can put in place? And we'll give some specific examples of some of your safety net peers that have gone down this road and faced a little bit of uncertainty or the unknown, and kind of how they managed that and ultimately came out at least unscathed, but oftentimes ahead of the game at the end of their demonstrations. And then lastly, what are the things that we need? How do we budget for them? Because part of this really does impact what we need to essentially invest in from a capital standpoint, as well as new staffing models, and even new compensation design. And those things really have demonstrated to make a pretty significant difference to organizations that wish to go down that path or down this path. And so we'll talk about how organizations have gone about doing this, really with a little bit of a specific focus on how they've overcome, I think, one of the most pressing concerns that some of you illuminated, which is many times safety net providers are not sitting on a wealth of capital to just make this one-time large investment to redesign or shift their care models. So how did organizations such as yours look at kind of incrementally making those investments, tapping into financial resources to allow them to do that so that they can ultimately make that shift? This is our framework, and it's going to kind of guide the flow of the educational content going forward. Are there any comments or questions before we move into defining value? Okay. So we're going to take a closer look now at the process of defining value. And this is a conceptual model, one that we think that is a useful tool when having internal discussions both with your staff, your board, even when you're discussing this with patients, frankly, that are interested and concerned, perhaps patients who sit on your boards or patients who are involved in some of your programmatic design. I'm going to talk through it in detail as we go through the conversation today. But I think what I really want to start with is an indication from me to you that what is really being asked of us is that we really begin to take accountability for populations of patients. So whether you're a primary care provider like a federally qualified health center or a behavioral health provider or a hospital, we believe strongly that the value-based reimbursement trend is really towards population health and being accountable for population health outcomes. And many organizations might say, well, that's something as safety net providers we've historically done very well. We, in many cases, are exposed to quality reporting and other standards. We've kind of had to do that, or we have grants that really, motivate us to essentially take that on. But there are some very significant differences in the value-based reimbursement world. And the largest of those has to do with patient attribution. And the way in which patient attribution impacts this is that in particular, as Medicaid expands or as patients enter the exchange insurance products, there is now an organization in most cases a managed care organization, private insurance organization, that receives financial resources essentially to care for that patient. In the case where there is no managed care, and in states where there is no private managed care for the Medicaid program, those dollars may actually be paid directly to a provider organization in an ACO-like relationship. And we'll talk a little bit about those two separate models. But that flow of financial resources, that's kind of a cornerstone of the Affordable Care Act and essentially the overarching health reform strategies that have put in place, really change or fundamentally change the relationship that is necessary from the primary payer source. So in the case of Medicaid, that's the state, the managed care partner, if one exists, and then ultimately the provider themselves. And so when we talk about value, despite the fact that this doesn't always necessarily feel good, because we feel that value should be much more tied to, is the patient healthier? But in the world of value-based reimbursement, value is typically defined as quantifiable monetary benefit that your care provides to a payer's patients. And that has a lot to do with the fact that the states in particular are looking for strategies that lead to cost containment. They'd love it if we could start rolling back costs, but even if at this point we could start to contain costs, that would be a significant move forward. And so virtually every value-based payment methodology will have some component of total cost of care built into it. And we'll talk about that in a second. It's a conceptual formula, and as such, it's not simple to just plug values in here and crank out a number, but it gets us thinking about the levers that we have at our disposal to improve our value. And we like to say that outcomes and cost factor into the equation, and they are in an inverse relationship. You'd like outcomes to improve. If nothing else changed, but you improved the quality of outcomes you could deliver to a payer, then in theory, your value to that payer has increased. If nothing else changed and you decreased cost, you deliver the exact same outcomes to the exact same population, but could reduce the cost of doing so, again, that would increase your value to the payer. And that's why we reflect outcome and cost in an inverse relationship. Now let's talk a little bit about outcomes. I think we're generally pretty comfortable with these types of measures, but these are measurable indicators of population health which demonstrate effectiveness of our care model. And every value-based reimbursement methodology will have some measurement of population health outcomes because even those that are extraordinarily high, and we'll talk about different payment methodologies later, even those that are tied to total cost of care very tightly, there needs to be some indication that you're achieving an enhanced or improved total cost of care without restricting access to patients. So if our quality scores go down and our costs go down, we've actually created no more value in that scenario. Again, why they're in an inverse relationship. I'm going to show you, let's talk about a couple of common outcomes in value-based payment models. On the left, I've selected a small number of outcome measures that are in place currently in what is probably the most widely implemented value-based reimbursement model, which is the CMS Medicare Shared Savings Program for ACOs. And I don't think many of these measures will be a surprise to you. For example, rate of issuing influenza immunizations to populations that are considered to be requiring that service, tobacco use assessment and cessation, hemoglobin A1C, blood pressure control, use of appropriate pharmaceutical therapy for coronary artery disease and diabetes, and then patient experience measures like how well doctors communicate and getting timely care appointments and information from my provider. In that shared savings program, it doesn't matter how much money, your organization saves Medicare. If you score poorly or do not report these measures, there's zero opportunity for you to receive that upside incentive. We took a look at a couple of different state-run quality programs or value-based reimbursement programs. On the right, you'll see a couple of selected excerpts from both the Vermont Medicaid ACO program as well as the Community Care of North Carolina Medicaid performance measures, and surprisingly familiar measures again. Colorectal screening, adolescent well care, screening for depression, use of appropriate pharmacological therapies, assessment of environmental triggers for asthma, and then blood pressure control and aspirin use. So I think generally speaking, these are familiar types of measures to us. I think most of us have experienced that at some point in our careers, if not currently, that measuring and improving in these areas matters. And these probably are the types of the actual very specific measures that you're probably very familiar with. Are there any questions or comments? Does anyone want to talk maybe about their experience with some of these measures and whether they have kind of an active program to improve in these areas?
Hi, it's David Nemiroff from the Long Island Federally Qualified Health Centers, and some of these things we are doing as part of our district program. So these are some things that the state of New York has asked us to look at. Tobacco use assessment cessation is a district project. Diabetes, the hemoglobin A1C is one. So a lot of these are very similar. The adolescent well visits and depression screenings are all part of what we're working on for our district projects within New York State.
Great. And can I ask, are they setting a benchmark or a threshold, or at this point are they just gathering data?
Yeah, so they've I think we're in what's called measurement year 3 now. They've given out to all of the participants around the state, this is your benchmark, this is the state's benchmark, and this is how far away you are as a global, what they call PPS, which is all the providers in a certain area, how far away you are from that benchmark for a majority of the things I see on this list. And then you have to do process improvement, gap to goal, and continually get better in order to get funding. Okay. In the case, the reason I ask, in the case of the Medicare Shared Savings Program, which is the measures on the left, that program in your first participation year, your performance against the measures is simply reporting them. And then that allows CMS to establish a baseline against which you are asked to improve. What that does, and folks kind of commented on risk adjustment being a concern, what that does is that actually kind of self-benchmarks you against your previous performance. That almost, not entirely, but almost takes the concern of risk out of the equation because you're being asked to improve essentially on a steady population. Yeah, they started year 1 as a benchmark, and then you had to improve from there. But for us, it was based on the Medicaid population.
Yep. So in other models where they ask you to compete against a regional benchmark, a national benchmark, in those cases, there are concerns that safety net populations are skewed to have other underlying risk factors, and it may not be fair to expect that, for example, 90% of all patients are below 140 over 90. That might be a national standard, but that over heavily weights traditionally insured, traditionally employed, or employer-sponsored insurance patients into that equation. So we're going to talk about risk in a second and how that factors into some of these models. Any other questions or comments? Okay.
Yeah, this is Chris with North Carolina. I was just going to say we're unique as the State Office of Rural Health in that we have state funds that are available to support the safety net system in a variety of different programs. And so we contractually have started to ask the safety net system, which is federally qualified health centers, local health departments that do primary care, school-based health centers, rural health centers, which are slightly different. They're state-supported, not necessarily rural health clinics, and then free and charitable cares to report on tobacco, hemoglobin A1C, hypertension, and we've had some talk about maybe expanding it to include some of the patient satisfaction measures next year. So really trying to work with the safety net system, aligning it with UDS reporting, but getting them all to sort of begin to look at this, even if they're not in an ACO model or their population isn't being managed by CCNC.
That's great. So it's there is some money to assist, but it's not as if they're taking on a wholly new payment methodology. However, you are getting that, you're kind of raising the awareness, raising the kind of urgency a little bit to learn these skills and how to impact these situations. Correct?
Right. So the resources we have are state appropriations that are generally intended to create access. So it might be that one of the safety net system is awarded a 3-year award, and the objective of that is they want to hire a new nurse practitioner and they want to create more access or evening access or something along that line. But we now add quality measures as part of the deliverables in that contract, so that we're a safe entity, but that they've got to get comfortable in learning this language and reporting it. I think the key for them, though, is to align it with what others are expecting. So not pick measures that are different than, because we have some FQHCs and ACOs, not pick measures that are different from UDS reporting or Medicaid, and really trying to be thoughtful in finding those ones that they're already capturing and reporting for other subpopulations.
That's right. Great. Thank you. All right, let's talk a little bit about some of the considerations. So one thing that I would suggest to you is quality measures are going to be largely familiar and are going to draw from recognized sources. My team's looked now at dozens, if not over 100 different configurations of value-based programs, and by and large, they are focusing on the same major areas. One thing that does have a fairly significant impact on what the quality measures will look like is the payer scores. Medicare and Medicaid, for example, will have different types of quality goals, simply because those populations have different health issues. But by kind of looking at the HEDIS, meaningful use, and UDS kind of measurement systems out there, we pretty quickly get to a couple of really key topics: hypertension, diabetes, well care, including immunizations and otherwise, and it starts to become. I think, a little clearer what we're being asked to do. That's not the same thing as saying that everyone's measuring the same outcome the same exact way. We know that represents a challenge, but we do believe that applying the focus and effort to improving some of these quality of care data elements, such as medications, labs, diagnoses, procedures, can really up our game. What I mean by that is making sure that even if we don't know precisely what we're going to be measured on, that our electronic health record systems really represents what's going on with a given patient in terms of these kind of key indicators is critical. The second is that these measures will be applied to the attributed population, not just the seen population. What I mean by that is that in virtually all value-based reimbursement models, there is an attributed population which may be very different from the population of patients who are active users of your organization. This is unavoidable, and this has to do with my opening statement about the allocation of financial resources to patients. That really puts a burden on payers, whether it's the state directly or private managed care, to then allocate or attribute that patient to a provider. And once that's done, regardless of how that patient behaves in terms of their use of that health system, the outcomes associated with that patient are tied to that provider. That means that we're going to need to gather data from new sources, specifically payer-provided data, so specifically attribution data or claims data, but it could also include health information exchange data if you happen to be in a state or region where health information exchange is a reality. That's not obviously in every region, although we're starting to slowly see some uptick in the number of regions that actually have meaningful health information exchange. It also means, regardless of what type of organization we are going to need new strategies around patient engagement. Because if patients aren't seeking care and our payment is tied to their outcomes, we need to find a way to try to engage them. And managed care should be a partner in that, but there is a high expectation, especially as safety net providers, that we identify strategies for how to do that such that these patients can get into care, begin being tracked more closely from an outcome standpoint, and that we no longer kind of have the excuse that they have not engaged with us, they will factor into our scoring. Lastly, patient experience measures are often included in the outcomes portions of value-based payment models. CAPS is kind of the predominant model. The full CAPS survey, and I'm certainly not endorsing in any way CAPS. I'm just suggesting that it is the one that was adopted by Medicare and is often adopted by statewide value-based reimbursement programs. There's a subset typically of those survey questions that are applied to the value-based payment reimbursement methodology. Payers view this as critically important because it typically affects or measures essentially the patient's ability to access care from their providers, from the organizations that they are attributed to. And that's one of the single leading indicators of whether improvements in cost, for example, are being tied to better care, or if improvements or costs are really being tied to reduced utilization on the downside of kind of less access to care. So this is going to require us to have a strategy for collecting and managing that information, and really requires us to apply a focus on access, our communication with patients, and really making sure that patients are playing a role in developing their care plans. Self-directed care plans are really the type of care plans that are scored highly from a patient standpoint. They're sensitive to patients' needs and also sensitive to the reality of the environment that safety net patients are living in. I do want to comment. There was one write-in comment that I probably should have addressed in the previous slide. There is a challenge, and we've identified this, and actually we're working with a couple of behavioral health groups. There is a challenge in terms of how to define appropriate measures of quality for behavioral health providers. The physical health side, I think, is a much more mature market in terms of how outcome measures have been brought to the table. But absolutely, behavioral health and oral health would be another consideration, not quite as mature in that regard. Another way, though, of thinking about it is the behavioral health markers and the impact that, the physical health markers, like the ones that we just showed on the previous slide, and the impact of right-sizing or improving access to behavioral health, and therefore the ability to then address some of the physical health issues, is how a lot of systems are looking at this, almost in partnership. So while there may not be in a lot of value-based reimbursement methodologies direct measures of quality for behavioral health, the organizations themselves are partnering on patients that have comorbidities between physical and behavioral health, and really looking at partnering to address specifically how to improve both, often with it kind of manifesting as improved physical health. Any questions before we move into cost?
So,
Amanda?
Andy, this is, yeah, sure. So this is Amanda Stangus from Starling Advisors. You guys heard from me last week. I just wanted to piggyback a little bit on the behavioral health issue that Andy just talked about and was just raised by Recovery Resources. One of the things that we see groups doing that are engaging in these models when they come from the place of behavioral health or community mental health is really focusing a lot on the risk assessment piece of the risk assessment and the risk screening of patients. And this becomes really critical and actually is a really strong skill set that behavioral health has at its disposal. And there are ways to build into your risk assessments and your risk screening process that are happening at the point of intake that help to identify some of the factors that link ultimately with what payers are looking to accomplish with regard to some of their models around this. And I think, there's, in some ways, diagnoses codes for behavioral health consumers gives you a rich way to identify how to identify your patient populations, and so to some degree, being able to link what how those diagnoses codes are connected to things like avoidable hospitalizations, but more importantly, care transition planning. Those are some of the things that we see folks doing. More and more, and this gets to the issue that I think was raised in the homework, but we'll continue to talk about when we start to talk about how do you fund and staff and resource appropriately care models. This idea of doing very thorough risk screening that includes behavioral health, I think, is a critical component of all of this. So that's where we're really going to look to our behavioral health partners to be able to, lay the groundwork for some of that. But just to the folks at Recovery, if you want to connect with me offline, I'm happy to share kind of an exhaustive list that another group has batted around in terms of what they see as some of those main factors are, and they may or may not, apply to your patient population. But at least I can share with you guys kind of how they've approached that and where some of their thinking has been.
Thank you, Amanda. We're now going to switch gears and we're going to talk about cost. In virtually all but the most basic of value-based reimbursement models, there's some element of cost of the population that factors into the payments made to providers. And we split costs into two buckets. There's the costs that we can control because they are costs derived by the work that we do as an organization, and that's what we refer to as the cost of us. And then there's the cost of everything else that patient receives that we have less control over because those costs are derived by things that we don't directly deliver to the patient, and we refer to that as the cost of them. And for each of your organizations, how those two costs are divided will be different because you will deliver essentially a different scope of services to your patients. A federally qualified health center might impact directly the primary care costs, some of the drug costs, and even potentially some specialist costs if they have in-house specialists. A hospital really focused more on inpatient stays, emergency department utilization, maybe perhaps surgeries and other procedures. And behavioral health practice really focused on the expenditure around providing behavioral health care. That would be directly the cost of us. It's the cost of the care we deliver to the patient and its relative efficiency. For example, keeping a population of patients healthy using less visits and more telephonic follow-up will be considered more efficient than using more visits. And many safety net value-based reimbursement methodologies hone in on this aspect of the value equation and really focus on things like alternative touches. So can we see the patient less frequently if we follow up with them in other ways throughout the course of the year? Organizations don't typically like to base their new compensation on this element of the equation because it typically involves reducing our unit reimbursement for services. And in a fee-for-service model, obviously we want to maximize our reimbursement on a per unit service basis. And so just this shift alone would not necessarily cause us to want to have to decrease that. Now, that's not the same thing as saying we don't need to find ways to be more efficient stewards of financial resources that are spent within our organization. And this really does divide, I think, the ambulatory care from the hospital-based care side of the safety net. For primary care specialists, behavioral health, and some oral health, a focus on alternative touches that reduces office visit utilization is really seen as kind of a critical strategy for being better stewards of financial resources. This creates opportunities to expand care teams, to better leverage new types of resources in pursuit of better care. You should have a downward arrow for RVUs and an upward arrow for panel size. In a lot of value-based reimbursement models that target ambulatory care, there are kind of per member per month or other types of payments specifically to do these kind of alternative pursuit or alternative touches to better interact with patients when they're not physically within the four walls of your facility. Well, that would value essentially a provider that could manage a larger panel, but would actually, in many ways, almost punish a provider that generated more RVUs on the same population size. So we want to take that into consideration under some of these new models that we need to be looking at utilizing our resources as efficiently as possible and finding ways to get paid for things that can prevent us from using some of the more expensive procedures that we deliver. For hospitals, this is different. The cost of us for a hospital will focus on things like length of stay, programs to better transition back to ambulatory care, diversion from expensive care settings such as emergency department diversion programs, and then improving adherence to discharge treatment plans so that patients don't end up either back in the hospital or back in other expensive settings of care. And so the impact is, a focus on or a need for enhanced discharge planning, medication reconciliation, health information exchange to the next site of transition, and then developing kind of cooperative partnerships with other settings of care. And we'll talk specifically about some payment models that we see working effectively for hospitals that are willing to do some of these things that really fall a little further down the payment model trajectory towards kind of bundled payments or kind of global payments for a set of services. Any questions on our cost efficiency?
Hi, this is Julie with Lutheran Social Services of Illinois. I just wanted to make a comment that in Illinois, where we're operating, the value is really, on the behavioral health side, is reducing emergency room and inpatient utilization. Yeah. They're actually looking to increase office visit utilization because it's just the climate that we're in right now.
That's right. For much of the safety net, the cost of us is probably not where we're going to focus. While there are some significant value-based reimbursement programs out there, the Oregon model, California's testing a model with some of its FQHCs that really do try to reduce the number of office visits. The overwhelming, we're going to talk about it now, the overwhelming impact is reducing what we call the cost of them or the cost of things that are happening outside of our organization. And it's a great point and one that we try to stress because this really does bring in a whole new set of skills and a whole new set of data that we need to manage. So the cost, we define the cost of them as the cost of care provided to your patients that's delivered outside of your organization and can be referred to as your cost effectiveness. So you can be as an organization, you can be evaluated by how much care people need to get elsewhere as a result of the care that you provide them. When a population of patients uses less inpatient days than projected, for example, the cost of care cost effectiveness of your care is considered to be higher. That would be a primary care or behavioral health example, for example. So basically, the term that gets used a lot in the value-based reimbursement world is total cost of care. And we're kind of creating in your mind, there's this Venn diagram of the total cost of care being made up of things my organization got paid to do for the patient and then everything else that anyone else got paid essentially to do for the patient. And most value-based reimbursement models heavily weight this side of the equation. When we look at things like shared savings programs, the real opportunities in shared savings programs are to reduce unnecessary utilization using kind of ambulatory care models or population health models. So let's talk a little bit about this. The biggest consideration, and really the only one that we've listed here because it's so important, is when your value-based model takes into consideration costs of things that happen outside of your organization. We just need to up our game on understanding the full utilization pattern of an attributed population of patients. And this is where a whole new set of skills that really bind or really force, I think, a different kind of relationship between financial leadership and clinical leadership come into play. The simple part of this is that it requires us to use claims data to study utilization. The stuff that gets way harder is what do you do with that claims data? So how do you identify expensive treatment options from claims data when equally effective treatments might be available at a lower cost? How do we look at emergency department utilization for ambulatory sensitive conditions and put in place programs to reduce it? How do we identify where medical beds are being used simply because we can't get patients transitioned or admitted into the psychiatric hospital bed that they actually need? Can we identify duplicative testing and make commitments within our communities to reduce it across different organizations? Can we look at strategies to utilize hospitalists? The list goes on. There's almost a never-ending list of potential innovations that can be applied to this problem, but it does stem from our ability to acquire, study, and then make meaningful information out of utilization pattern and utilization data. For virtually all safety net organizations that we've ever worked with, this is a new skill set. This is not something that's been kind of part of the standard operating procedure up to this point. So we're going to focus some of our discussion about managing and then budgeting are really going to focus around acquiring this skill and effectively applying this skill. Do any of the organizations on the phone have experience working with detailed claims data? I think we might have gleaned some of this information in our first session, but I wanted to kind of revisit it.
This is Chris with North Carolina. We certainly have the Medicaid claims data that CCNC makes available for the Medicaid population. So our RHCs, our FQHCs have access to that data through a portal where they can see utilization patterns, find high ER users, can see children behind on well visits, those sorts of things. It's mingled with ADT data out of 80 hospitals, provide real-time admissions data. But I will say I don't know how sophisticated the practices are at using that data at grade level. But I think often it's the care manager at CCNC that uses that data. So it's available, but I don't think practices are using it to the degree that they could. But
Right.
have a benefit of having a tool at least.
Okay. So I think what you're saying is that they can access it on an individual basis, but in terms of kind of sophisticated strategies to put that to use, maybe we're not as mature there.
Yeah, and I think for us, this is Misty from Piedmont. I would echo that. I think it's just taking a further step with just the content expert on staff to be able to help you look at that data and figure out how do you actually have access to the information.
Right.
Just to add to that just a little bit more is there's the data team that needs to be able to access the data, use the data to, identify the patterns of specialists or whatever it might be. But then there's the team that has to put that in place. You have to change workflow process. You need new staffing to do something about it. And that's also a huge challenge.
Absolutely, yeah. Just to give you a very specific example, working with a group of rural hospitals that are trying to improve, trying to actually reduce this number, bullet number 3 here, use of medical beds when psychiatric beds are not available. There's a very limited number of psychiatric beds. They're very far away from one another because it's a very high rural market. And they just don't have the psychiatrists on staff in the emergency departments to get that admission completed. So they're looking at telehealth solutions that actually help reduce that cost burden on the system because they've identified it as a true barrier. Well, how did they identify that? By looking at the claims data and seeing what a significant cost associated with inpatient days tied to behavioral health diagnoses, where they literally were just waiting in that bed. They felt they legally could not discharge those patients, but they couldn't get them to where they needed to be. So that's a kind of a concrete example of how this data and information could be used a little more strategically to identify these drivers in our communities and in our markets. That's probably not being, just being frank, probably not being done as consistently throughout the country as will need to be going forward. Okay, I'm going to move us ahead and talk a little bit about the last two parts of the equation. So you could generate really great outcomes at a really effective cost, but have a really simple population to manage. Or you could deliver really great outcomes at a really great cost and be dealing with a very acutely ill population or a population that had a lot of social, unmet social needs. How risk factors into this equation, there is not yet a one single or even a small number of best practices, but they are starting to emerge. And it's important to understand that our outcome and cost profile in the eyes of payers needs to be adjusted for the underlying risk of the population. Risk is a measure of the impact of certain factors on cost of care in particular. That's how plans have traditionally used it. For example, a population with a high incidence of chronic disease has more underlying risk than a population of patients with no chronic disease. And your value is impacted by your ability to identify and address these risk factors. Unfortunately, we're going to talk about risk and risk adjustment. Unfortunately, in kind of the current day and age, the majority of risk modeling is done on disease data, ICD-9 or ICD-10 codes, so it doesn't factor in social acuity or social determinants of health. That's changing, and it's changing rapidly with the experience of early plans, particularly in the exchange, who found out that the patients were more acutely ill than they thought, and not all of that was tied to physical health issues. Much of it was tied to either behavioral health or social determinant of health related issues. But our value is impacted by this risk in a couple of different ways. If it's not taken into consideration, a safety net provider could be negatively impacted by having outcome scores, for example, that were lower than a private physician office that was used as a benchmark of performance. That's one way. Another way that risk gets used is to adjust the magnitude of premiums or care coordination payments paid to paid to the provider as the result of new value-based reimbursement models. And one example is in many states, the Section 2703 of the Affordable Care Act created the opportunity for states to receive a disproportionate 90% match on payments to medical homes that focus on patients with chronic conditions. Well, some of those payments go up to $100 per member per month for patients that have a lot of comorbid chronic diseases because the cost savings opportunity was so great with that population. So risk factors in a number of different ways, but there's also a set of skills around risk management, and risk adjustment that need to be taken into consideration. First and foremost, risk drives the premium side of the value conversation, meaning patients who have more risk have more money allocated to them in that attribution process. So when your health plans get a contract from the state, they get paid differently for patients with different underlying conditions. If you enter into an ACO contract with Medicare, the amount of expenditure, total cost of care allocated to an end-stage renal disease patient is about 7.5 times higher than the amount of financial resources associated with a general Medicare beneficiary. So that's really important to understand. And of course, nobody would advocate for overcoding, but undercoding, particularly in the safety net, could be a significant barrier to really having the right amount of financial resources to manage patients under a value-based reimbursement methodology. It's important, we feel, for safety net providers to understand which ICD-10 codes and other codes are used in risk models and code accurately and completely. This is particularly true for safety net providers who have historically received an encounter rate or PPS payment or whatever it might be, regardless of what the disease state was or the severity of the appointment or visit was. Without that motivation to be exhaustive in our coding, we frankly aren't telling our payer or the state the underlying conditions that a patient has, and therefore aren't having the right amount of financial resources allocated for that patient. So accepting a shared savings on a patient population that's improperly risk adjusted puts us behind the 8 ball out of the gate. Second is risk scoring is being used to place patient into risk tiers, which varies the intensity of care coordination. And in these models, provider organizations such as yourselves are essentially creating panel sizes for care coordination or community health work or whatever type of population health management approach you take so that those patients are adequately covered across the board. This requires a need for comprehensive risk data, including social determinants of health, to kind of right-size that care coordination intensity that is provided to patients. So patients at a certain score, risk score, might be impaneled to a care coordinator at the rate of 100 to 1. Patients with a much lower risk score at a rate of 1,000 to 1 if they're only doing kind of every 3-month follow-ups on general wellness. Another consideration, another impact, we feel safety net providers as they make the transition to value-based reimbursement models should be seeking direct reimbursement for care coordination services and then budgeting according to appropriate care coordination panel sizes. That's not available in every value-based reimbursement model that we've seen, but it's certainly in some of the, I think, kind of more progressively designed models is being seen as that kind of transitional model that addresses the concerns that we discussed earlier about where do I get the money to make this shift, to hire these new people, and to test this out. We've seen a lot of willingness for organizations to partner on this, specifically managed care plans. If there's kind of an underlying business plan that says, here's how I'm going to cover these patients, and here's what I'm going to focus on in terms of addressing those patients. And there are also public funding options for these programs. I mentioned already the Section 2703 of the Affordable Care Act, where a state can create a direct reimbursement for care coordination services program for the chronically ill populations that are served by medical homes. So there's some options here for how to make risk work to our advantage. We have to know how to kind of take the right steps to address them. Any questions about risk? Okay, let's talk about then our last. Yeah.
Andrew? Yeah,
Yes.
This is Jeff Brown with the Maine Primary Care Association. I just wanted to sort of augment this characterization of risk and the importance of thinking about how our systems of care may be inducing harm. And just an example, if you take a look at diagnostic code, and so you got a patient with a depression diagnosis, and they're being treated with an antipsychotic. We're actually introducing metabolic problems. We're seeing, it's really important to start using risk triggers to understand how we may be inducing harm and risk to the patient and financial risk too. So I just wanted to add that in. If folks want to start taking a look, beneath the hood a little bit, they may find even more opportunity.
Yeah, that's great. I think that's a really good point. I think that one of the things that we want to make sure is that we don't create these evidence-based practices that are so rigid that they kind of trump common sense. And I know from my early days in an endocrinology practice, the argument was always, for example, with the elderly population, how aggressively are you really going to try to manage that A1C simply to improve your quality score, when the reality is it's not a positive impact on quality of life for that person. So certainly I think it's a very valid point, and thank you for introducing it. There was a question that came in over chat. What was the ACO section that mentioned that states can design a reimbursement for care coordination? It's actually Section 2703 of the Affordable Care Act, and it's the patient-centered medical home reimbursement program. It's a 2-year option for states to receive a 90-10 match on money that they make available to patient-centered medical homes who treat patients with one or more chronic condition. The states have a lot of latitude to design their specific individual program, but the feds will fund it at a 90-10 match. That was still available as the last time we've checked, although it's been around for several years, and some states have already implemented, and in some cases have already used the first 2-year match. Missouri has a very robust one that's, I think, 4 years in now, meaning even after the 2-year match, the state decided to keep the program in place and fund it at the lower match. So Section 2703, if you want to research that further. Okay, our last component of the value equation is scale. Scale means to us a lot of different things, but I like this definition. It's our ability to deliver a consistent care model to a larger and increasing population of patients. It's inclusive of access. Access is a really critical component of scale, and the ability to deliver care in a timely fashion without unnecessary delays, of course, is kind of critical, we believe, to doing value-based care delivery effectively, and we'll talk a little bit more about that. But scale is bigger than access in our eyes, and the way to think about it is the old math, lesson of any number times 0 equals 0. Well, you might be really high quality as measured by your outcomes. You might deliver at a pretty low cost, and you might be able to handle really complex patients or populations of patients But in the eyes of those who wish to engage with you from a payment standpoint, if you can't do that for one more patient or 1,000 more patients, you don't have very much value to them. There's not a lot of reason for them to incent you with new types of payment models that theoretically might pay you more. Part of value-based reimbursement is growing those practices that are good at the stuff on the left side of the equation, in the middle of the equation there. So what this means is that we need to be able to be responsive to the needs of the population. This is particularly true as we discuss that attributed versus seen population. My outcomes might be great. I might manage the patients that see me very effectively, but what happens if 40% of the patients that my health plan expects me to be managing have never seen me? And I need to get to those patients if I wish to be successful under this model. How am I going to rise to that challenge? How am I going to grow my scale consistently to meet the needs of that population as well? A couple of things to consider. We feel that most sectors of the safety net will need to grow to meet this new demand. This means a focus on really being repeatable in our implementation and use of health IT, our design and propagation of care team models, our development of facilities that support these new models, and our clinical leadership. And there's no small challenge in those 4 bullets. We know that. Nobody's designed the perfect care team model to begin with, so how can we effectively propagate it? Health IT has been a significant and costly challenge. We're probably just feeling like maybe we're turning the corner on using health IT as part of our underlying business model. We need to be able to, add a new provider, get them ramped up, get them working effectively in a care team setting. Our capital planning probably already includes new facilities or redesign of facilities. That's already putting pressure on us, and we've got to invest in all this other stuff too. Second consideration, access is a key predictor of health outcomes and cost. So identifying within our systems ways of getting patients to the lowest cost, most effective care as quickly as possible is critical under most value-based reimbursement methodologies. So if, for example, a hospital can develop transition of care programs where the care is continued or followed in a community-based setting that's of lower cost, but they can also point out or demonstrate that that led to 1 less readmission or 100 less readmissions, that is going to increase our value. So we need to find ways of fostering and building those types of relationships. We should seek contracts that pay for access and find ways to demonstrate adherence to access levels. You could look to negotiating different incentives around getting patients into community-based care where appropriate within a certain period of time. We will likely wish to grow panel size. And again, we've referred to this before, but seeking care coordination models that allow for alternative touches and then applying those models to really right-size the amount of face-to-face encounters that patients use, really across all types of settings of care, because that allows us to grow panel size, allows us to have more access to the attributed patients. And if we are in a model that pays us to do that work, we can do so and be margin positive. This is not a sunk cost that we're being asked to bear simply to perform better from an outcome standpoint. And then another consideration would be evaluating and potentially implementing telehealth, really to expand access to key services. I talked about situations, I talked about the example of getting patients transitioned more quickly to psychiatric beds, and in doing so, utilizing telehealth-based psychiatrists to make that referral and get them to the right point of care, the most effective, lowest cost, most appropriate care setting as quickly as possible. Scale's probably the most esoteric one, although I think we've tried to give you some really concrete examples. These are all the things that you're going to be asked to think about as you undertake various value-based payment methodologies. I'm going to spend a little bit of time talking through a couple of payment methodologies today. That's not going to be the focus of our conversation today. We're going to get into much greater detail with those in future sessions. But with each one, you could now start to apply this value-based equation or this value equation and figure out where the real triggers are in each of those plans. Any questions on scale before I begin to wrap us up this morning?
This is Collins with the North Carolina Office of Rural Health. I have a comment just to share with folks. We worked with our Medicaid program, and we've been able to get approval for 90-10 match, 90% federal. We have to come up with the 10% for a health information technology team that's going to go out and support the rural and safety net system in terms of helping them with using EHRs, connecting to our HIE, which is a state law that we have in place, as well as beginning to help them in terms of looking at quality indicators. So that was just approved, and we're in the process of vetting the program manager job description to post. But maybe a resource other states want to look into.
Sure. Yeah. There's a lot of kind of hidden 90-10 matched opportunities in both the Affordable Care Act and other associated laws, and I think that it kind of behooves us. And our focus in this session really isn't about advocacy strategy, but getting involved with statewide associations that can actually help shape some of those programs as a way of breaking down some of that investment challenge associated with this shift. There was a question that came in over chat. Are there reimbursement methodology in place for nutritional services and health promotions? The answer to that question is very complicated. There certainly are, Medicare tends to be the leader on expanding the CPT code set, if you will, that actually paves the way for there to be direct reimbursement for those types of services. State Medicaid programs are pretty slow to follow, and then even if the state Medicaid program follows, that doesn't necessarily mean that the individual managed care companies immediately follows. The good news is that we think you're operating in an environment where if you can demonstrate that that's having an impact on one of the quadrants or one of the sections of the value equation, we think it behooves you to have that conversation with those that pay you directly and try to create that. My team will look for that. We'll take that as a follow-up to see if we can find anything that's directly paying for those types of services. I know, a lot of, there are some movements towards paying both for annual wellness exams that can include some of these components, but also Medicare now has a non-face-to-face planning and education of patients that could really stem into just about any aspect related to the patient's health. And, there's some nuances to that program. I wouldn't say it's targeted directly at nutritional services, but certainly is directed around health promotion. And so there's starting to be some examples out there, and we'll take that as a follow-up. Okay. We only have about 10 minutes, but I want to kind of stop and just ask, maybe one or two of you can weigh in. We've thrown a conceptual model at you here, and we're going to get more specific. We're going to talk about how different value-based payment models kind of impact this. But do we feel good about our ability to talk about our value and to essentially take the step of aspiring to a different value based on impacting some of these parts of the equation? And if so, or if not, what are the tools and capabilities that we would need to do that better? If anyone wants to comment, we only have about 10 minutes, but I did want to see if folks wanted to kind of weigh in on this. Well, we're going to follow up with you guys in terms of both the homework and then your final projects really are going to be about using the value equation as a lens to look at the type of interventions or programs that you wish to develop moving forward. I'm going to keep us moving ahead. I want to make sure that you get teed up both for session 3 as well as for the homework assignment. So we wanted to kind of talk about the various value-based payment models and how everything we just talked about kind of is a lens by which you can look at these. On the left, we took these from the Learning Action Network around alternative payment methodologies, and it kind of puts payment methodologies into 4 buckets. Category 1, or 4 categories. Category 1 is fee-for-service with no link to quality or value. Category 2 is a link to quality and value that really revolves around what we would kind of call pay for performance, and is very heavily weighted in the outcome section of our value equation. Then there's models that begin to move into the upside and downside gain sharing. So these are models that start taking into consideration really start taking into consideration that cost part of the equation. And then category 4 is condition-specific or population-specific payment models that almost take the whole equation into consideration. We're going to break these down a little differently, and I'm going to actually show you. I'm going to ask you a question to think about between now and next week in each of these areas. We talk about transitional models starting with fee-for-service, so minimal change, and adding care coordination payments. So basically just adding to our existing reimbursement. That's not really, I just want to be clear, that's not really a value-based model because it does not kind of meet the goal or the does not meet the most important test of our payments varied tied to some evaluation of outcome. However, it's an important transitional model to understand. The next would be pay for performance, which is where you receive some upside if you achieve certain outcomes. Then the very commonly used shared savings model, which looks at the total expenditure of a population and incents providers to manage that better. Bundles or episodes are very specific, tied to very specific episodes of care, such as a congestive heart failure admission and the associated clinical follow-up. Models of partial capitation are when the provider is paid for a subset of the total set of services. And then, of course, full capitation, which is where essentially the provider manages the full budget associated with all benefits associated with that patient. And each of these makes different parts of that value equation a bigger and more important part of our response. These are the questions that I wanted to kind of pose to you. I'm not going to stop after each one. Unfortunately, we don't have enough time today. I'd like you to think a little bit about these before next week, and maybe we can have some discussion at the beginning of the session, in 2 weeks. In a fee-for-service care coordination model, would it make sense to accept a deal where I gave you $10 per patient per month to provide care coordination services and support navigation of these patients through the healthcare system? Sounds great until you start to think about, well, what's the infrastructure I need? What's the staffing levels that make sense? So it may or may not be a good deal. Would you accept in a pay for performance a reward payment of $60 per patient every year that you provide 80% of those patients with an annual wellness exam? This is an actual example from an actual Medicaid pay for performance program that really heavily weighted getting those attributed patients in for care long before they actually were sick enough or warranted more episodic care. Again, though, is this a good deal? A lot of risk here if you're going to apply a whole bunch of resources to try to outreach to those patients if you don't hit it, right? Shared savings model. Would you be willing to take half of all savings generated against the cost estimate for all Medicaid patients assigned to your organization? Ton of questions about whether this is a good deal. Does it impact our underlying reimbursement? How many patients will we be attributed? How are those cost benchmarks set? So many things to think about before making a determination as to whether to enter into this. This is one of my favorite examples. Would you take $25,000 for all care associated with an inpatient stay for congestive heart failure and 6 months of follow-up, including any rehospitalizations? This is a really interesting one because the way in which that 25,000 number is typically set has to do with a certain percentage of patients being readmitted within the 6 months. If you can drop that number, then in theory, the average cost per patient is going to go down. You can start pocketing and reinvesting a pretty substantial amount of money. This is a Medicare, typically associated with a Medicare type population, because congestive heart failure is typically a disease that manifests later in life. And the other reason this one's particularly interesting is because some care coordination models have shown that you can drive readmissions to near zero with appropriate in-home follow-up of these patients. So a lot of area to explore. Would you take $200 per member per month for each patient with diabetes to provide them with all primary and specialty care services? It's $2,400 a year. Most Medicaid patients don't have that much premium allocated to them at all. But a ton of questions here about the full scope of services. Do we need to contract with the specialists? Do we need to set up infrastructure to pay the specialists if they don't operate within our organization? And then full capitation, would you take $3,600 per year for each of your patients to provide them with all covered benefits under your state Medicaid policy? Virtually impossible to answer this question without a ton of additional information, most of which would have to do with risk adjustment, historical utilization patterns and costs, as well as a prediction of what we could impact. I'm going to jump right to homework, and then we're happy to hang on the line a few minutes after. We want to be respectful of folks' time. But for next week, we'd like to get to know a little bit better the infrastructure you have today. So we've asked you, and this will be set up in the SurveyMonkey. We've gotten that kink worked out. We want to ask, we want to have you respond and let us know, do you have the ability to track outcome measures? Have you evaluated and implemented any kind of plan for alternative touches, such as telephonic follow-up, in-home monitoring, and text message support? Do you receive cost and utilization data information from at least one plan? Do you have a process for assigning a risk level to each patient? And do you use this to alter the clinical pathway for patients according to their risk level? And do you have a plan to increase your access to patients to meet the needs of all patients attributed to you by payers? You'll find this in the SurveyMonkey link along with the evaluation of the lesson today. We look forward to reviewing your responses, and we'll use them to tee up a more robust conversation at the beginning of next session. But with that, I am going to ask, if there is any discussion or question and answer, we'd be more than happy to take that at this time.
So it looks like we're answering the question, if we don't have enough information, should we be jotting down what information we would need in order to make a decision?
Yeah, these are going to be free-form, open text box answers, and we just want to know kind of where you stand. So obviously, taking some time to think about what your organization has the capacity to do now, or even what you wish you had the capacity to do in the near future is really all we're asking. It's really just to kind of get a sense, based on what you heard today, based on all the skills necessary to make this work, what's the gap? Where are we starting from? Does that make sense?
Yes, it does. Thank you.
Great. Well, I'll hang on the line for about 5 minutes. Otherwise, you folks are welcome to go about the rest of your day. Thank you for joining us, and we look forward to the next time we have to interact with you folks.
Thank you.